Dr. Anthony Fauci first changed the world by developing therapies for formerly fatal rheumatological diseases, and through his work on HIV/AIDS, he has had additional impact through his relentless advocacy for and clear communication about science, so clearly on display throughout the COVID-19 pandemic. He has helped the world face and overcome the two greatest public health crises in the last 40 years, HIV/AIDS and COVID-19. Without further ado, please join me in welcoming Chancellor Marilyn Miranda and Dr. Anthony Fauci to the stage.
Thank you. Thank you so much for being here. Thank you. Thank you. Thank you.
So thank you to all of you for being here with us this afternoon. It's a really special day for UIC to be able to host you, Tony, Dr. Fauci.
Thank you.
Our classics department really wanted to have an individual session with you. Time did not permit that, but the first question I'm going to pose to you comes from our classics department, which is, your training reflects a deep interest in the humanities. You received your bachelor's degree in classics from the College of the Holy Cross. Share more about the intersection and importance of your humanities background with your aptitude for science and how you ended up being a physician and researcher.
Well, Marie Lynn, my training in the humanities and classics really is much more to the core of who I am than the classic issue of the fundamental basic scientist. I mean, obviously, I spent my entire career as a scientist and as a physician scientist. But when you go back to early on in my life, when I was trying to decide what it is that I wanted to do with myself, I was much more interested in people, in humanity, in civilizations, and how people responded to different stresses historically. So I entered into a course in high school, which was a Jesuit high school, which was steeped in the classics, and I really got very taken up by it. In high school, as much as I leaned much more towards the humanities and the classics, and in high school I took 4 years of Greek, 4 years of Latin, 3 years of French, and a bunch of other things. I also took biology and chemistry and decided that I really loved science, but I never lost that affinity towards the humanities. So Holy Cross College, which is another Jesuit school in Worcester, Massachusetts, had a very unusual pre-med course, the name of which would raise your eyebrows. So I graduated from Holy Cross with a Bachelor of Arts - Greek Classics - pre-med, which actually is in and of itself an oxymoron. But it was enough credits in the sciences to get me into medical school, but very steeped in the humanities and the classics and in philosophy. How that influenced me is that it made me, in all of my dealings, the time when I was seeing hundreds of patients during the AIDS years and subsequent to that, to be more interested in the person with the disease than the disease in the person. And I think that made me a much, much better physician. I carried that over to the NIH. And when I got to the NIH and was challenged with a number of sequential public health crises, with HIV, the anthrax attacks, Ebola, Zika, and then COVID, it all had a profound effect on society. And my training that was equally balanced between understanding societal issues as understanding a molecule or a clone or a pathological function, again, I think made me a better director at the NIH. So it's steeped in everything I've done, from taking care of the individual patient to doing experiments that involve and impact large numbers of people to actually running a big institute.
That's great.
Okay.
You know, an interesting thing we share in common is that I did not study Greek, but I studied Latin and French in high school. I also went to Catholic school, and I picked the high school that I went to because it was the only girls' high school that taught Latin. And
Really?
in order to teach Latin, they pulled Sister Lucia out of the coat cupboard to teach me. But it was really, it was so influential on me. Okay, let's talk about your early days at the NIH. So in your early days, you began working on immune regulation. And that's been at the heart, really, I would argue, of your decades-long scientific contributions. You're viewed as a pioneer in the field of human immunoregulation. In this work, you developed effective therapies for until then fatal immune-mediated diseases like polyarteritis nodosa, granulomatosa with polyangiitis, and lymphomatoid granulomatosis. How did you get interested in this work, and how did this work shape your thinking about the role of NIH in health and well-being?
Well, I'm glad you brought that up because most people think I was born when AIDS started, and I'm really much older than that. Sorry. It is what it is. So when I was training in medicine in my internship and residency, it was the very early incipient years of understanding the human immune system. A lot of really good scientists were doing a lot of very sophisticated work on mouse, guinea pig, and rabbit immunology. We were just starting to understand the complexity of the immune system. And when you think of the immune system, when the immune system is functioning correctly, it protects you against infections or helps to respond so that you can recover from infections. In some respects, it protects you from the emergence of tumors in your body. However, the immune system can underfunction when you get immunodeficiencies, either natural congenital or induced by an infection like AIDS, or it can over and aberrantly function, giving you autoimmunity. So when I was studying medicine in general, I was struck by a whole group of diseases called the inflammatory vasculitides, which was, as Marie Lynn said, uniformly fatal diseases. They were uncommon. I wouldn't say they were rare. They were uncommon. So they weren't major public health issues. But if you got one of those diseases, you almost certainly died. Yeah. So I felt a great deal of frustration in patients that I was taking care of as a resident. So when I went down to the NIH, I took a combined fellowship in infectious diseases and clinical immunology. So when you're in medicine, for the medical people in the audience, you graduate medical school, and then you get a subspecialty and you get boards. So I had my boards in internal medicine, then I had my boards in infectious disease, and I had my boards in immunology.
You're very
So
bored.
one of those guys can't make up his mind, right? But the combination of infection and immunity was very, very fascinating to me. When I went to the NIH, my mentor happened to be accumulating a number of patients with inflammatory diseases. A subset of them had autoimmune diseases that involved the blood vessels. So we got this idea, which was a very bold idea, but which was controversial at the time, was we wanted to suppress the immune system just enough to shut this aberrant immune reaction that was destroying kidneys and lungs, but not enough to make the person so immune suppressed that they would die of an infection. So as an infectious disease person, I used to make rounds, clinical rounds, as a consultant at the National Cancer Institute, whose purpose was to wipe out your bone marrow and wipe out your immune system, not to make you get infected, but to kill the cancer. So we got the idea that if we used one of the drugs that they used in very high doses to kill the cancer, with the secondary deleterious effect of suppressing patients to the point that many of them didn't die of the cancer, they died of the infection. We used very low doses of that drug that when you titrate it, it brought down the aberrant immune response just enough to shut the disease off, but not enough to make the person vulnerable to infections. And there was the cure of these diseases. So at a very young, early age, I was fortunate enough to be in the right place at the right time and to be, I guess, bold enough to use a drug that people are saying, you really want to use a cancer drug in someone who doesn't have cancer? That was very, very antithetical and controversial at the time. But once it worked, then you became a hero. So then the people who were criticizing you started praising you. Right.
Well, you are a person of great humility, but you also know that I think of you as a hero 3 times over. You just talked about the first time over, all the work that you did on immune-mediated diseases, and we're going to get to the other 2 as well in our conversation this afternoon. So some of you who are here may be aware of the Paul H. Douglas Award for Ethics in Government, which is presented annually to a person whose public actions, writings, or other contributions have made a significant contribution to the practice and understanding of ethical behavior and fair play in government. The event is organized by the University of Illinois System Institute of Government and Public Affairs. And in March, I want to congratulate you and mention that you will be receiving, mention to the entire audience, that you will be receiving the U of I System Paul H. Douglas Award for Ethics in Washington, D.C. during a ceremony hosted by President Queen. I want to make sure I get out a ceremony hosted by President Killeen and Senator Richard Durbin as well, Senior Senator from Illinois. So I have a question related to this. You advised 7 presidents on domestic and global health issues. I want to focus for a moment on one particular health issue. Talk with us about your time spent working on HIV/AIDS research at a time when there were many unknowns and stigma around the disease. What ethical and social challenges did you face?
Yeah, well, as some of you may remember, we first were confronted with AIDS, HIV, in the summer of 1981. And I began working, it was just very briefly, I don't want to take too much time on it, but as Mary Lynn said, I had been working on this autoimmune disease that was very successful career trajectory for me from 1972, when I finished my chief medical residency in New York and then came down to Bethesda at the NIH, to 1981. Then in 1981, in the summer, a Morbidity Mortality Weekly Report, which is the weekly report from the CDC, landed on my desk reporting very curious 5 young, interestingly, all young gay men, 5 from LA, who presented with this pneumonia that you only see in immune-compromised people. This was June of 1981. I thought that was a fluke. I said, it was some drug that was taken to enhance sexual satisfaction, which can suppress the immune system. Then 1 month later, in July of 1981, a second MMWR came, this time reporting 26, curiously, all young, otherwise well, gay men from LA, San Francisco, and New York, who not only had pneumocystis pneumonia, but had Kaposi sarcoma, which is, again, only seen in immunocompromised people, and other opportunistic infection. At that point in July, I made up my mind, which I still can't dig deep down and figure out exactly. I just felt this compelling need of empathy and scientific challenge all in one. Empathy towards these young gay men who were being stigmatized not only for being gay, but stigmatized because they had a disease that was a mysterious disease that was likely sexually transmitted. So I just felt, and it's only me personally, I felt an almost fundamental ethical responsibility to say, I'm going to change the direction of my career and start studying this disease that didn't have a name. It wasn't AIDS, it was gay-related immunodeficiency. Didn't have an etiology, which was only discovered in 1983 and 1984, and I devoted all of my time doing it. It was a very unusual time then because you were trying to do research, but the patients were so sick that you had to spend essentially all your time on the ward taking care of patients. That, doesn't fall under the idea of classic ethics, but to me it was kind of a moral responsibility because nobody else wanted to get involved in this strange disease. Some people didn't even believe that it was worth doing because it was involving a disenfranchised group of people, which is, when you think about that, that's
heartbreaking.
Yeah.
So you were one of the architects of the President's Emergency Plan for AIDS Relief, PEPFAR as it's commonly called, a program that has been credited with saving more than 20 million lives throughout the developing world. What do you think motivated President George W. Bush to push for this initiative? How did you think about the best way to structure the initiative?
Well, for those of you not familiar with this, what Marie Lynn was talking about is the President's Emergency Plan for AIDS Relief, or PEPFAR. So back during that evolution from 1981 to 1996, we gradually developed enough drugs that were life-saving for persons with HIV, to the tune of, by the time we got from 1996 to 2000, 2001, the drugs got so good and were given in a way that was so user-friendly. We used to start with 28 drugs to be given over a period of every 2, 3, 4, 5 hours, which even the drugs that were life-saving were very disruptive to the life of the persons whose life was being saved by the drug. By the time we got to 2000, 2001, we could give a person living with HIV a single pill containing 3 drugs that would essentially give them a normal life expectancy, maybe cutting off a year or 2, back when in 1981, when I was taking care of individuals, their life expectancy was 10 months. So you went from 10 months literally to almost a normal lifespan. So it was a time in my life when I had no drugs and all of my patients were dying, to the time in my life in 2000 when I had access to all drugs and all of my patients were out living, enjoying life, developing relationships, contributing to society. However, in one part of the world, in sub-Saharan Africa and in the Caribbean and other low and middle income countries, the doctors and the nurses there were like Tony Fauci in 1980, only it was the year 2000. Namely, they were seeing persons with HIV, and they were all dying, not because there were no drugs, but because they couldn't afford the drugs that were saving the lives of other individuals. So I had gone to Africa multiple times until then, and I was totally convinced that if we put resources and gave it to individuals in Africa, that we could prevent and treat disease. There were many people who felt, and this was probably subliminal, if not overt racism, didn't think you could treat Africans with sophisticated drugs that you had to take. So nobody was interested in doing anything about it. I got very exercised about that and wanted to do something about that. And lucky for me, And lucky for the world, so did George W. Bush. So, you know, people have different opinions about the Bush presidency, but I can tell you when it comes to public and global health, he called me into the Oval Office one day. I got to know him very well from the anthrax attacks. Remember, the anthrax attacks occurred in October of 2001. He called me into his office one day and said, you know, I feel, this was his words, I know they were because I wrote them down, that he said, we have a moral responsibility to not have people die from a preventable and treatable disease merely because where they happen to have been born. And he was referring to Southern Africa. So he said, I want you to go to Southern Africa and put together a program that is transformative, and accountable. And I told him in the Oval, I said, Mr. President, that's going to probably cost a lot of money. And his exact words were, let me worry about the money. You just put together the program. So I went again to Africa and came back and felt that it was feasible, that if you gave them the money and the drugs, they would take it. I was totally convinced. And the reason, because for the small amount of drugs that they had, they were as diligent in taking their drugs as people in Chicago or in New York. So I came back to the president and I presented it to him and said, I think we can do it. He said, okay, put the program together. So for the next 8 months, with his staff, who were very cooperative, people whose names you don't know or will ever know, but were core people at the White House, I put together a program that ultimately was designed to treat 2 million people, prevent 7 million infections, and care for 10 million people, including AIDS orphans. And I proposed $15 billion over 5 years. The president accepted it, announced it at the State of the Union address on January 28th of 2002. It's 2003, I'm sorry, 2003. And then 20 years later, he came to Washington with his wife, Laura, and the team that put it together. And we had a celebration at a place in Washington, downtown Washington, D.C. And at that point, we did the tally. We had invested $115 billion, and we had saved 25 million lives. And that was the PEPFAR program. And we have the President of the United States. And that just goes to show you what presidential leadership can do. When you have a president who's inspired to do something that's really transformative, it can happen.
Yep, absolutely. I'm just going to take a little sip of water from my favorite mug. Those of you in the audience may not be able to see this, but there's a portrait of Dr. Fauci on my mug. So that's hero number 2 for me. It's really the work that you did on HIV/AIDS. It is something. You have changed the world.
Thank you.
On to a question about health equity, coming from one of our MPH students named Nicole. Given the intersection of socioeconomic factors, racial disparities, and healthcare access, how should we envision shaping public health policy and practice to address immediate crises and proactively dismantle systemic contributors to health inequities?
Well, Marie Lynn, that is a question, that's a two-part question, but it's separated by something you can do now at the local community level. And, and we have seen that, I talk about lessons learned from COVID, and one of them was the fractionation of our healthcare delivery system, which feeds inequities. So if you look at COVID itself, that's a typical example of individuals in the community who didn't have good access to health care, mostly minorities, but other people many in a socioeconomically lower level didn't have access. So we need to correct that as quickly as we can to give better access by putting accessibility of clinics into the community. And you guys do that really well here at UIC. I know that, and that's really good. The other one is something that I always refer to as, the social determinants of health. But the social determinants of health are present because they date back to their root cause, which goes back centuries and decades. It's steeped in slavery, racism, and discrimination. So when we say, well, we're going to address the social determinants of health, the social determinants of health mean that someone who, when they're born, they don't have a good diet, or they have a diet that feeds into being obese when you're 20 years old, or feeds into hypertension, or feeds into diabetes. So you have a 25, 35-year-old, 40-year-old African-American or Hispanic person, but mostly with African-Americans because of the situations that they've been through. COVID comes along, and who are the people that when they do get infected have a higher level of hospitalizations and death? Those with obesity, hypertension, and diabetes. So it's no secret that people whose social determinants that date back before they were born are now suffering because of what happens to their health. So the way we're going to do that is that we as a society have to make a decades-long commitment to turning around the social determinants of health. We can't do it in a 2-year term of a congressman or a 6-year term of a senator. It's got to be society making a decision that we're going to address it in decades.
This is a place where I feel that universities can play an incredibly important role. As you mentioned, we have clinics operating in low access neighborhoods on throughout a very important geography in Chicago. But we have faculty across many different colleges and schools that are working on these social contributors to health outcomes. And the thing about universities, we're not on a 2-year time horizon, a 4-year time horizon, or even a 6-year time horizon. We are one of the institutions that's on a decades-long horizon, and so I view universities generally, I certainly view UIC as an incredibly important partner in addressing these social correlates of health. We're proud to be part of that, that endeavor. A related question from one of our professors in urban planning and public policy, Sanjeev Vidyarthi. What top lessons emerged from the recent pandemic that mayors and urban planners can use for future-oriented planning in big cities like Chicago? And I'll mention that we have Mayor Lightfoot here with us in the front row. So.
The reason I'm smiling is because under Mayor Lightfoot and your health person, Allison Arwady, Chicago did as better as anybody else. And I'm saying that not because I'm in Chicago. That just happens to be the truth. So one of the things that has been one of the 4 or 5 or 6 core reasons why, as a nation, we didn't do as well as we should have with COVID. As I was mentioning a bit to the press people a bit ago, prior to the COVID outbreak, the Johns Hopkins School of Public Health ranked different countries as to their preparedness for a pandemic. And the United States was ranked overwhelmingly the best. And at the end of the outbreak, we had 1.17 million deaths. And the outbreak isn't even over yet, but at the end of a 4-year period, we are now in our 5th year of this outbreak, which is more deaths per capita than virtually any other country in the world, including low and middle income countries, with maybe one exception. And one of the reasons was the fractionation at the local public health level and our healthcare delivery system. Because decades ago, we had a great local public health system. We had the best and the brightest became public health officers. Then when we had vaccines and antibiotics and antivirals, we became victims of our own success. So when people left the public health arena, they were not replaced. Funding was much less than was needed. And so our otherwise really good local public health system, with some exceptions, we did not do very well with what public health at the local level could do, would be to identification, isolation, and contact tracing. We didn't have the resources to do that. So you always heard us talking about, we can control this by identification, isolation, and contact tracing. But all of that takes place at the local level. And if you don't have local public health infrastructure, no matter how devoted and committed the people are, if they don't have the resources, it's not going to happen.
So a question from a person in allied health sciences, Joe Wagner, wants to know, hindsight is 2020. Is there anything you would have done differently in response to the COVID pandemic and rollout of the vaccine?
Yes. No, I mean, when you're dealing, and this is something that sometimes people have difficulty grasping, understandably, I'm not criticizing, is that when you're dealing with a moving target, then you have to make decisions based on the information, the data, and the evidence that you have. If the target is moving in a scientific public health arena, you have to move with the target. So what happened and what we knew in January of 2020 was very different from so many standpoints than what we knew in July of 2020 and in April of 2022 and more. Let me give you some examples. In the beginning, we thought, understandably, this was a coronavirus. We had a coronavirus in 2002. Remember the original SARS? It was very poorly transmitted from person to person. It went from an animal, a bat, to a civet cat, to a human. And the efficiency of transmission from human to human was really very poor, and it was controlled by public health measures. That's what we thought in the first week of January. Then a week went by and we found out, whoa, wait a minute, it's transmitted pretty well from person to person. And then 2 weeks later, we found out it's transmitted better than any other respiratory virus that we've ever dealt with. And then a month later, we found out it's spread by people who have no symptoms. So the syndromic approach of stay away from somebody who is sneezing and coughing, that was almost a useless, paradigm, because people were spreading it who had no symptoms whatsoever. Then the virus did something that we never saw that within respiratory virus. Multiple different variants. We've had now 6 variants and about 20 different subgroups of Omicron. That is completely unprecedented. So the short answer to your question, if I knew in January what I know now, we would have done a lot of things different. But what the society needs to understand is that when scientists change their recommendations, that's not flip-flopping. Right. That's what science is.
That's what science is. That's right.
I mean, I always say when I try to explain it to some politicians sometimes, I say, in and of itself, that's it. But for example, when you're talking about science, there's physical sciences, mathematical sciences, and biological and health sciences. The latter are the ones that evolve. In math, in January of 2020, 2 + 2 = 4. In July of 2023, 2 plus 2 still equals 4. But the virus in January of 2020 was very different than the virus in July of 2023.
Okay, but I'm a mathematician.
Uh-oh.
So 2 plus 2 does equal 4, but our understanding of mathematical systems also evolves. And we have a fantastic mathematics department here at UAC. We do. You know, it's interesting. I think what you're referring to is this whole how do people deal with uncertainty? How do they react to it when you, because that's what we're trying to say about science. We don't know everything for sure. It's going to change. It's going to evolve, and people aren't comfortable with that. And I remember very vividly, I think many of you know that my youngest child was treated for cancer when she was in high school. And when the doctors came in and told us, you know, we're talking to my husband and myself and my daughter about what the treatment regime was going to be like and what the possible endpoints would be. They talked about the uncertainty, and they said to us, you know, I know you would prefer it if we could give you absolute certainty about things. And my husband is also essentially a statistician. I'm a statistician, and we looked at our doctors and said, if you told us you knew this with certainty, we wouldn't believe you, right? Because we are really trained in this Bayesian, updating, how to think about probability distributions, et cetera. And I feel that that is one of the things that we need to do a better job at both the high school and the college level of teaching that ability to think about things in a realm of uncertainty. So there's a quote of yours that I really love, and I keep it in a place where I see it regularly. And here's the quote. For people who are not responsible for policy, it's very easy to make a prediction. So I especially like this quote because it reminds me of the difference between describing problems and solving problems. Talk a little bit about how do you balance being open to critique and input while still moving forward, especially in the face of uncertainty or incomplete information.
Yeah. Well, with regard to that quote, but I'm glad you dug that up. You did your homework. They were back in the early years of both HIV and COVID. People who were not experts in the field would make a prediction of something that would happen. They have no responsibility, no line responsibility. They have no responsibility for anything. So I made the comment that when you're not in charge of a policy and don't have any responsibility, it's easy to make predictions. Because if you're right, you're a hero, and if you're wrong, nobody cares. So that's what I meant by that. But what the second part of your question there is, Marie Lynn, is that I listen to everything everyone says, because no matter what, unless they're completely insane, which is very, very unlikely that people are going to be, you know, making kinds of comments about things, about how well a job you're doing it right. There always seems to be a bit of a kernel of truth, maybe very small, in what they're saying. So I always give voice and listen to what people say, as opposed to just blowing them off. That was something I did early on in the years of HIV, when the gay activist community were saying that the government was too rigid in the design of clinical trials, that the inclusion and exclusion criteria was too rigid, the regulatory approach towards the approval of drugs was not well suited for a disease that were killing people in 10 to 15 months. And it was my listening to them and realizing that what they were saying was actually quite true, even though they were being confrontative, even though they were being iconoclastic and theatrical. Listening to them made me understand better what we needed to do. So the lesson of that, to the second part of what you asked, is always keep an open mind about other people having input into helping you figure out what you need to do.
Yeah, and I think that is a message that is incredibly relevant for us, for everyone. on our campus and throughout the world today. I oftentimes quote a colleague of ours here at UIC who talks about the incredible importance at this moment in our history to have the maturity to acknowledge the partial truth in the argument that you disagree with. Right. So that, taking that frame of mind where I'm going to listen carefully and try to learn wherever I go. Recognizing the importance of engaging the younger generation, how can we encourage and harness the active participation of youth in shaping public health initiatives?
Well, that's essential, because when you talk about the future is youth. It's not that older people that don't have an important role in it, but if you really want to talk about where the future of anything, of a university, the future of a city, the future of a country, it's in the youth. So in fact, that is one of the things when people ask me what I'm doing right now is, after the half a century that I was involved in basic and clinical biomedical research, what I'm doing right now is to try and hopefully inspire youth to get involved in a meaningful profession. Hopefully, some of them will get involved in public service. But the point I want to make to people is that public service isn't only official, designated public service, like if you work for the federal government or work for the city or work for the state. You can be in a job that many people have that is contributing to the public service. So if you could just think about, let me get involved in something that gives to society rather than something that takes from society. So that's what I'm trying to do when I go around and talk to people.
Yeah. I think you're managing to inspire a fair number of people in this room as well. So you were the subject of threats because of your high-profile role managing COVID. What advice would you offer others on managing the chaotic and sometimes hostile environment currently in play?
Yeah. Well, we live in a very, very divisive society now. You don't need me up here to tell you that. You just need to, turn on CNN and then turn on Fox, and it's like you're in two different universes. My advice to young people is to don't let that deter you from pursuing your dreams of public service, if it's public service or whatever your dream is. Public health officials are now being the object and target of a lot of threats, merely for saying what's true to people to preserve and protect their public health. It seems rather paradoxical that public health officials who are trying to help people stay safe are being threatened because of what they recommend, like get vaccinated or wear a mask. But my encouragement to the younger individuals is that the gratification and the satisfaction and what you can accomplish in the arena of public health overwhelmingly outweighs the negative aspects of it. So I wouldn't let that deter them. Okay.
So we have a question from two different people, one in nursing, one in the graduate college, that are on the same theme, which is in an era of increasing misinformation, how do we restore trust in science, research, and health professionals? What strategies do you believe are most effective for scientists and health professionals in communicating complex health information to the public?
Yeah, the only way to we are living in an era of misinformation and disinformation at a level the likes of which I don't think this country has seen ever, maybe, but certainly in my lifetime. And the only way to counter misinformation and disinformation is to get the people who care about truth, integrity, and the correct information to be actively out there talking about those things. It just seems that the people who are spreading the misinformation and disinformation are doing nothing but that. It's almost like they don't have a day job. Whereas the people who are the sources of the correct information have things to do with themselves, and they can't spend full time trying to counter the misinformation. But the only thing I can encourage them, particularly the young people in social media, get out there and counter this amazingly deep issue of disinformation. Don't give up. The one thing that we can do to make a big mistake is to accept the normalization of untruths. Right now, there's so much untruth going on that many people just shrug their shoulders and say, well, you know, there's nothing you can do about it. Whereas decades ago, if somebody egregiously lied, they would be shamed. Now, when you egregiously lie, you gain in popularity. Mm-hmm. So it just seems to me that we can't accept that. The younger people particularly need to push back on this normalization of untruths. Otherwise, if you don't do that, then nothing is going to be seen as true, and anybody can make up anything they want. And if you look back, getting back to my classics background, yeah. If you look back on the history of civilizations, that's when democracies crumble, is when there's no truth and there are people that can just spread any kind of lie they want to do. You don't have to go back too far. Go back to Europe in the late 1930s before World War II, when that's how it started.
Yeah, there's a long history of decline in democratic institutions, that decline being associated with the beginning of restrictions on what people could read and what they were allowed to say, et cetera. Yeah. It's a horrible history in our world. So you're here on a college campus. We're in the business of training people to be doctors, to be nurses, to be pharmacists, to be business people, et cetera. What could we be doing differently, or what should we take up as we try to prepare students to be able to fight disinformation and misinformation?
I think you should be doing what you're doing. I mean, you're trying to and succeeding in educating younger individuals and doing it in a really optimal way, where you're doing it with a great degree of diversity, with a great degree of appreciation for the fact that there are, you know, many views in society. People come from different backgrounds. It's what the universities are doing. I like being here because you're doing it, and your student population is an extraordinary group of individuals. I mean, I can relate to them. I understand many of them are first and second generation from people like, my grandparents were born in Italy. They came over and landed in Ellis Island at the turn of the century. And probably one of the reasons I want to get involved in public service is that my father and mother, who were the first generation of people born in another country, passed it on to me that you kind of owe society, because we live in a wonderful place and you kind of want to pay back. So that's what you're doing. Yeah. So go for it.
Yeah, there we go. You know, it's interesting. My family is immigrant. I was the first one in my family born in the United States, and my father, may he rest in peace, at the end of his life was a very long and difficult battle with Alzheimer's disease. And one of the things that I remember is him talking over and over and over again and asking the question over and over and over again, are you glad that we came to this country? I think it was very important that we came to this country. Are you glad that we came to this country? And so even as so many parts of his mind were deteriorating, he held so fast to this idea that the opportunities available to him and his wife and his children were going to be fundamentally different, which to me is like the United States at its best. When we are at our best, that is what we're doing. We're providing that kind of opportunity.
I agree.
So we have a law school student, Matthew Maton, I'm sorry if I'm mispronouncing your last name, who wants to know, well, he wanted to know 25, but I'm moving it to 20. If you could go back to when you were 20 and give yourself one piece of advice, knowing what you know now, what advice would you give? You can give 2 or 3 pieces of advice.
I'm going to surprise you with this.
All right.
I would probably, now that I'm at the age I'm at, and look at what I've been through over these years, I would probably try and torque a little bit more work-life balance differently. I did not have a work-life balance. I had a work-life imbalance from the time I got out of medical school, probably because I was continually confronted with another crisis, HIV, anthrax, Ebola, et cetera. And I'm not sure I would have accomplished that much less if I paid a little bit more attention to other things. I mean, my wife is a typical example of that. She's a highly accomplished medical ethicist. She's the chair of the Department of Bioethics at the NIH. And she went to every crew meet, every soccer game, every swim meet, every diving meet, and missed nothing and still had a highly successful career. I missed a lot of that because I was, in the middle of the night taking care of a deathly ill person with HIV. I wouldn't do it any differently, probably, but if there's one thing that I look back that I wish I could have done differently was maybe spent a little bit more time with my family. Right.
Yeah. I spend a lot of time, as I'm sure you do too, mentoring people who are coming up in our fields. And the phrase work-life balance, I oftentimes tell them, it's balance. Work is part of your life. Figure out how much you want work to be defining your life. Don't think of it as, now I'm in this place and I'm working, and now I'm in this place and I'm having a life, because hopefully you're picking, this relates back to your public service, hopefully you're picking work that is very meaningful to you. I would just like to offer there's a grateful nation and a grateful world to the person who I consider a hero 3 times over for the many choices you made to advance the way that we treat particular diseases, but also advance the way that we uplift people who are disenfranchised in society and say to them that you matter. That the fact that other people are shunning you doesn't mean that I'm not going to treat you, that I'm not going to work as hard as I possibly can. So we have a little gift bag for you. It's got some UIC swag.
Thank you.
Please use it often and tell people how great UIC is,
because
we are great. We are great. And I started off by talking about how, for me, you're a hero 3 times over, and I was reflecting on what I would say to wrap up this chair chat. But we had an alum, Catherine Kennard, who wrote in something in the questions, and I think she encapsulates much better than I ever could in her words what I would like to say to you, what I think the sense I'm getting from the crowd would like to say to you. So she has an MPH from 2002, and she says, as a public health professional, I just want to thank Dr. Fauci for leading those of us in the trenches with compassion, vision, and thoughtfulness throughout the dark, dark, dark days of the COVID-19 pandemic. Although we tried to prepare for a pandemic over the years, actually experiencing the extraordinary challenges and trauma a pandemic entails was hard to have ever imagined. That, on top of your long, distinguished career, thank you for leading when we needed you most.
Thank you. Thank you. Thank you. Thank you. Thank you. Thank you so much. Thank you. Thank you.